Okay, welcome back. Sorry for the delay. I know this is going up Wednesday. As you can tell, I'm wearing a different shirt. But let's finish up talking about healthcare. All right, so we just finished talking about adverse selection and how the Affordable Care Act was designed and some of the provisions of the Affordable Care Act that hopefully work to counteract adverse selection. All right, and once you start talking about the Affordable Care Act, you kind of easily segue into talking about different health policies, different systems of healthcare that are found throughout the world. And so obviously we should start at home, or the United States. I know not all of you from the whatever. Okay, so which is the third-party payer system. That's the name for the healthcare system within the United States. All right, and it's called the third-party payer system because a third party, in this case, Americans' employers, are financially responsible for paying for people's insurance. All right, so about half of Americans receive their insurance through their employer. Okay, so the rest are covered through government programs like Medicare and Medicaid, and then there are some people without insurance. The ACA has helped close this gap by establishing these marketplaces, but still most Americans receive their insurance through their employer. All right, and this has become kind of a fact of life, but when you really start to think about it, it's kind of weird, right? Because, you know, if you ask, why does your employer provide you health insurance, maybe you say, well, I like health insurance. But the kind of question there is, why don't employers provide other sorts of goods in kind? You know, I like housing, so why doesn't my employer pay my rent? Why don't they pay me, you know, a stipend for my rent, and then a giant gift card, and then a gas gift card, right? Why do they just, why not they not just give me all of my salary in kind, you know, if they're paying my insurance premiums? Is such a good idea. Right, and the easy answer is that, you know, classic result in economics is that paying people in kind rather than cash cannot make them better off. All right, it can either make them equally worse off or equally better off or worse off. Right, because if I value, you know, let's say I'm given $1,000, right? There's a ranking of things I would like to purchase with that $1,000. Okay, so if health insurance is number one, then I'd be indifferent between $1,000 in health insurance. But if health insurance is number four, and, you know, number one is, you know, a new car, you know, you can't get a car for $1,000, bear with me, then I'm made worse off, right? Because I'd rather have the $1,000 and thus the car than the health insurance premium. Okay, so it's kind of weird that American employers pay their employees insurance premiums rather than just giving you money and then you buying an insurance policy on your health the same way that we insure our cars and our houses, right? Our employers don't pay for those. They just give us money and then we purchase them ourselves. It's also worth noting that really no other country has this system. We'll talk later. There's a myriad of different healthcare policies that different countries have, but none of them have this unique system where most people get their insurance through their employer. Okay, so where did this come from? Right, the answer is in World War II. The United States government enacted price controls. Okay, price and wage controls. All right, maximum price and maximum wage controls. All right, and we talked about this back in week 3 of the class. Right, so remind or think about what is the consequence of specifically think about this maximum wage control. Okay. What kind of problem would that create? All right, so this is the labor market. And then, so, you know, you've got your equilibrium wage here, your equilibrium quantity of labor here, and then we're going to put in a maximum wage. All right, we haven't talked about this before. We've talked about a minimum wage, but we've talked about other maximum price controls. Okay, so we say you can't charge this wage here, you have to charge this wage here. So what that's going to do is that's going to increase labor demand, but it's going to decrease labor supply. Okay, so employers will want to hire more people, but fewer people are going to be willing to work. Okay, so ultimately, remember, this is a test question, the amount of people actually hired is going to fall from this quantity here to this quantity here, all right, because fewer people are willing to work at the lower wage. All right, you're going to have a shortage of labor. Okay? But there was sort of a loophole in the wording of the price control, all right? Because they only capped the maximum wage, the actual dollar amount that the employers can pay, all right? They didn't set a maximum level of total compensation. Okay, so what could firms do to get around this? All right, they'd like to raise the wage to hire more people to clear this shortage, but they can't do that. All right, they can't offer higher wages. So what could they do? They offer to pay your insurance premiums. Okay, so they say, okay, we'll pay you this low wage here, and then in addition to that, because we are not allowed to raise wages, we'll also pay your health insurance premiums. And doing that clears the shortage. Okay, so that's where this all started, was there were price controls during World War II, and in order to boost the quantity of labor supplied, because firms couldn't offer higher wages, they instead offered to pay employees' insurance premiums. The question then is, why did this continue after the war and the price controls were lifted? Well, insurance companies kind of lobbied Congress, and Congress made it so that premiums that you paid for your employees were tax deductible, and so that's how we kind of got stuck with this third-party payer system. All right, so what are some issues that arise from this? Okay, the first one is a lack of price transparency. All right, when you are shopping for, you know, any other insurance policy, you're typically very concerned about the price, right? You know, car insurance companies advertise their premiums all the time. Health insurance companies never do this. Why? Because you don't really shop around for an insurance policy, you just get the one that your employer offers. Okay, so that's going to lead to a lack of competition and a difficulty in accommodating non-traditional employment. Okay, so if you are self-employed, you're not able to get health insurance, so this might lead to a lack of startups, right? People not starting as many businesses, maybe people being less willing to quit their jobs. And all of this has led to Americans paying a very high percentage of GDP in healthcare costs. All right, so compared to the rest of the world, we are definitely an outlier. Okay, and a lot of this, or some of this, is due to this third-party payer system and this lack of price transparency. All right, there's still some debate about what exactly causes this. Part of it might be that Americans just consume more healthcare. There was a piece I might link to that argues, and somewhat convincingly, not everybody's convinced, but it certainly made a splash, that Americans being richer or having more disposable income can explain all of this. Some people disagree. Maybe it's because our prices are higher because of this price transparency issue. Maybe we just consume more healthcare. But the fact is, Americans consume a much higher percentage of their GDP in healthcare spending than all other countries. And this is probably because what makes us unique is our third-party payer system. Okay, so what kind of healthcare systems do all these countries have? So it's a common misconception, especially among politicians, that, you know, U.S. has private healthcare and then everybody else has public healthcare. Maybe in the broadest sense that's true, but in reality there's a much wider diversity of healthcare systems in the world. Oops. Yes, that's not going to play. Alright, so one solution before we get into other countries to the third-party payer system is what are called health savings accounts. These are really popular among certain groups in America. I think Trump ran on this as part of his campaign, so we should at least talk about it. The idea here is that rather than paying for your insurance premiums, your employer puts money in this tax-deductible account. Okay, so you still have that tax-deductible status, and then you can then take this money and buy whatever insurance plan you please. Okay, so this would significantly ease the price transparency problem. People who don't like this argue that you still would have to deal with adverse selection and moral hazard as sources of rising costs, but this is a system that people propose. Alright, so let's talk about other countries. Okay, so there are multi-party payer systems or multi-payer systems, where the government typically mandates that you purchase insurance. That's the key unifying feature. Okay, which is, again, why would the government mandate that you purchase insurance? Primarily to deal with this problem of adverse selection. All right, healthy people who don't plan to consume a lot of healthcare might not buy insurance, so we force them to in order to kind of subsidize the cost for everybody else. Okay, but you can mandate that people purchase private insurance, kind of like what Obamacare did. So Switzerland has a system where there's no government health insurance companies. Basically, the government forces you to just pick among a variety of private insurance plans, and then the government subsidizes them if you can't afford them. Countries like Germany, you have to purchase insurance, and you can either purchase it from the government or you can get private insurance. There's been some discussion about doing this in the United States. This is the idea of the public option. I think people called it Medicare for all who want it, right? So you can either buy private insurance, which is typically better, or you can buy public insurance, which is cheaper, right? And then the other form that this multi-payer system can take is that you have to buy public insurance, but this public insurance is very limited. It only covers certain catastrophic things, right? It doesn't cover like prescriptions or certain elective procedures or dental, whatever. And so on top of that, people purchase private insurance. So the Netherlands have that. Okay, so these are very common. But the other variety of system that people seem to be discussing a lot is what's called a single-payer system, which is actually more rare, but people seem really interested in it. The two main flavors of single-payer system are Canada's, where basically there is no private health insurance. The government is the only insurance company, and everyone has to purchase insurance through the government. Okay, so that's why it's single payer. There's only one insurance company, and it's the government. The UK also has a system like this, but the difference between the UK and Canada is that the government actually runs the hospitals in the UK, whereas in Canada they're privately operated. We talked about this during the education lecture, right? How there's a difference between government provision versus government financing of a good, right? So Canada is government financed but not government provided. UK is government financed and provided, though they've started to privatize portions of their government provided healthcare for some of the reasons we discussed. Okay, but when talking about these single payer and also partially multi-payer system, where there's really only one insurance company, what model is relevant? Okay, there's only one buyer of insurance, right? That's a monopsony. Remember, we talked about monopsony in the labor and immigration lecture. What would we expect a monopsony in healthcare to look like? Well, we would expect a lower price, okay, because there's no competing insurance companies to buy services from the hospital, right? There's only one government, so the government can bargain prices down, but in exchange, you're going to have lower quantity, okay? So lower prices, but also less quantity, okay? Is that what we see in the real world? Yes, so single payer and other more kind of government-run healthcare systems tend to have longer wait times, exactly what we'd expect with this lower quantity. United States, Switzerland, Netherlands, places with more private health insurance systems have much shorter wait times. And then the other thing is less quantity. Because prices are lower, quantity supplied falls. You're not going to want to put a bunch of money into developing, say, a new drug if you're not going to be able to sell it and recoup those costs. And that's exactly what we see, where almost all new drugs nowadays are patented in the United States, because the United States is pretty much the only place where drug companies can recoup the cost of researching and developing new drugs. So there's this great article from Brookings where the head of the British FDA essentially thanked the United States because it's our consumers who are paying so much for drugs that we're essentially subsidizing the rest of the world's innovation. So we talked in the externalities lecture about how innovation creates positive externalities. So in this sense, other countries with different healthcare systems are kind of free riding off innovation that's happening in the United States, because the United States is, again, the only place where drug companies can still make a substantial profit and recoup those losses. Okay, so we've talked about the economics of health insurance, but just as important, right, is the economics of health care. So this is pretty much talking about, how are things paid for, right? But what about the actual, stuff we're buying, right? The first question we should start with is, how much does healthcare actually affect people's health? Okay, and this is also a good test of your instincts on setting up empirical questions, right? Because the obvious thing to do would be to just compare people with and without health insurance, or compare people who spend a lot of money on healthcare versus people who don't spend a lot of money on healthcare, and compare their outcomes, right? But hopefully you've already spotted that there's going to be this huge endogeneity problem here, right? Because people who have health insurance, right, they probably have jobs, right? So maybe they're getting better nutrition, maybe they're more conscientious, more likely to engage in healthy behaviors. Maybe people who spend a lot of money on healthcare do so because they have some chronic condition, right? There are all of these omitted variables that make it hard to, just from observation, determine what the effect of healthcare on people's health actually is. All right, so remember in the empiric lecture we talked about how the kind of gold standard for answering questions like this would be a randomized trial, right? We'd like to take people and randomly select them to either have healthcare or not, and then compare their outcomes. And luckily for us, people have actually done this. So the biggest one is called the RAND healthcare study, and it's a randomized controlled trial where essentially they just randomly gave people different levels of health insurance. Okay, so some people had no health insurance, you just had to pay list price for everything, and other people, everything was free. Okay, and then we can compare differences in health outcomes between the free group and the people who paid full price. And what did we find? Surprisingly, or unsurprisingly first, people in the free healthcare group consume more healthcare. Okay, so that corresponds to an elasticity of negative 0.16, so that's inelastic, right? That's what we'd expect, but it's also negative. Sometimes when you talk to non-economists about healthcare, they talk as if it's one of those goods with a vertical demand curve, right? You'll pay anything. This experiment shows that's not true. But more importantly, what did all this extra healthcare get people? Did the people in the free healthcare group actually experience better outcomes? The answer, no. Okay, so this is kind of surprising. Okay, so the only positive effect that the free healthcare group experienced was eyesight. Okay, because they got free glasses and they could see better. All right. Another, this is just one study though, but there's been another one that's kind of similar called the Oregon Medicaid experiment, where they randomly assigned people to either get Medicaid or wait an extra year to get Medicaid. Okay, and this is a similar, randomized controlled trial. We can compare the group that got Medicaid to the group that had to wait during that year, and basically similar results. The Medicaid group spent more. No real difference in health outcomes. The only difference was the people on Medicaid had lower rates of depression. Maybe they were less stressed financially. And, this is interesting, had higher self-reported levels of health. Okay, so what do these results imply for health policy? Why might people be spending so much on healthcare that doesn't get them anything? I'm going to link to a podcast with GMU economist Robin Hanson, where he gives one interesting theory. So that's going to be in this module. So listen to that if you want to know more. Be sure to email me with any questions. I'll hopefully do another lecture this week answering people's questions about healthcare. Two things you might want to think about are occupational licensing of doctors and prescription drugs in the FDA. Those are topics we can cover more. If you want to ask questions about them, just let me know what you want to cover. Hope everyone is staying safe. I don't really have an outro. Don't forget to like and subscribe. That's my outro. Sorry for the delay. Stay safe, everybody. See ya.